Welcome back to the Deep Dive. Today we're tackling a really critical topic.
Yeah.
A deep, systematic look at the complications that can arise from general anesthesia. For anyone who really needs to master this, whether you're studying for a major exam or just trying to grasp the gravity of making these acute decisions, I think this discussion is just non-negotiable.
It is absolutely mission-critical knowledge. While anesthesia has become incredibly safe, the potential for a really rapid catastrophic failure is what defines the crisis management part of our specialty.
Right.
So our goal today isn't just to list off a bunch of complications. We're going to approach them systematically, exactly how an MD examiner would want you to.
Okay.
We'll be prioritizing the underlying mechanism, the why, then the crisis management protocol, and above all else, prevention.
That systematic approach is so important, isn't it, for turning facts into something you can actually use in a crisis. So let's start by defining our scope. When we talk about GA-related complications, what kind of time frame are we actually looking at?
Good question. So the standard definition is any morbidity or mortality that happens within 30 days of the procedure. That's what hospitals and regulatory bodies usually track.
Okay, 30 days.
But, and this is a key point, you have to be aware that some things, especially neurological events like postoperative cognitive dysfunction or POCD, they can show up and persist way beyond that 30-day window.
So the insult from the surgery and the anesthetic can have these really long-lasting effects.
Profound lasting effects on the central nervous system, yes.
The whole history of patient safety in anesthesia is kind of defined by failures in that recovery phase, isn't it? Could you talk a bit about why we have the safety systems we have today?
Certainly. The evolution of modern anesthesiology was really driven by some tragic early data. Early on, historical studies found that anesthesia-related respiratory depression.
So the patient just stops breathing properly after they leave the OR.
Exactly. That was the main cause of death or permanent brain damage from the anesthetic itself. And this discovery directly led to the creation of the post-anesthesia care unit, the PACU.
It was a direct response to that risk.
It's a mandatory response. It recognized that the emergence phase, that transition back to consciousness, is fundamentally the most vulnerable period for respiratory failure.
So to build that framework for our listeners, how should we categorize all these potential issues? It sounds like both timing and the body system are important.
They are. They're the two axes of how we manage and diagnose things. First, we classify by timing.
Okay.
So we look at problems that come up during preoperative optimization, then the high-intensity intraoperative crisis, and finally the postoperative recovery phase, so the PACU and ICU.
And the second way?
The second is by system. We break it down by which physiological system is affected: airway, respiratory, cardiovascular, CNS, and so on. And for every major topic we cover today, we are going to be really strict and follow that sequence you see in high-level exams. Cause, then pathophysiology, then clinical features, prevention, and finally, management.
That structure really forces you to understand the why behind it all.
Exactly. It forces mechanistic understanding.
Okay, let's unpack this and jump right into the area that, it demands the most immediate high-stakes decisions.
Yeah.
The airway. The data, especially from those big audits, it's still a stark reminder that airway failure is a persistent threat.
It is. The UK's National Audit Project 4, NAP4, was a landmark study on this. It showed that even with all our modern technology, failure to manage the airway can still have a mortality rate as high as 1 in 50,000 anesthetics.
Wow.
They identified 133 major airway events, and 16 of those resulted in death or permanent brain damage. It's why airway management is, and always will be, the foundational pillar of our specialty.
Okay, so let's start there. With difficult mask ventilation and difficult or failed intubation. When you face that, the immediate thought is usually the patient's anatomy, right? A short neck, a small jaw.
Yes, and that's where people can get led astray.
How so?
Well, while those patient factors, a known difficult airway, severe obesity, obstructive sleep apnea, are huge risk factors, the common thread in major incident reports is actually something else.
What's that?
It's inadequate assessment and poor planning. The difficulty was often predictable, but it went unanticipated. Or, if they did anticipate it, the plan B wasn't good enough.
So the failure is more operational than anatomical.
Precisely the point an examiner would make. It's an operational issue, not just an anatomical one.
So prevention really just boils down to being vigilant and having a solid strategy.
It's non-negotiable. Prevention means a thorough preoperative airway assessment, your Mallampati score, neck movement, all of it, and crucially, having a proactive plan for what you'll do if the unexpected happens. You have to have your rescue devices and strategy ready before you push that induction agent.
We focused a lot on induction, but you mentioned the risk isn't over once the tube is in. In fact, it seems like the extubation phase carries a really high, maybe even increasing risk.
This is the paradox of extubation, and it's a favorite topic for advanced clinical discussions. Claims data, particularly from the ASA closed claims database, shows a really disturbing trend.
Which is?
While we've gotten much better and reduced claims for death and brain damage during the high-stress intubation part, the claims for injury during extubation and recovery, they haven't decreased at all.
So the risk can actually be higher when you're taking the tube out.
Arguably, yes. Clinically, it can be a more dangerous period.
But why? The patient is supposed to be waking up.
Because you're transitioning from a totally controlled state to a potentially agitated, uncooperative one.
Right.
And you're doing this with an airway that might now be compromised by the surgery itself.
Like swelling or bleeding.
Exactly. Think about head and neck surgery causing edema, or thoracic surgery with bleeding and secretions. The Difficult Airway Society, DAS, has great guidelines for this. You have to ask 3 things.
Yep.
1, was the airway difficult at the start? 2, has the surgery made it difficult now? And 3, does the patient have other risks, like severe heart or lung disease that would make even a minor obstruction catastrophic?
Let's get into some specific extubation problems, starting with the most dramatic one, laryngospasm.
Right. Laryngospasm is it's a defensive reflex gone haywire. It's an uncontrolled, sustained closure of the vocal cords. The cause is almost always some kind of airway irritation, suctioning, blood, saliva, combined with the patient being in that light transitional phase of anesthesia.
And is more common in children, I believe.
Overwhelmingly common in pediatrics, especially after an inhalational induction.
How does this actually look to the clinical team? Is it always that silent, complete obstruction we hear about?
Not always, and that's a key diagnostic point. The clinical features really depend on how severe the obstruction is. A partial obstruction gives you that noisy, sonorous breathing, sometimes called crowing or stridor.
But the real crisis is total obstruction.
The real crisis is total obstruction, complete silence. You'll see that classic rocking movement. The chest goes down while the abdomen comes up on inspiration. When you see that, profound hypoxemia is just seconds away.
How do you manage that kind of high-pressure situation?
You follow a clear, escalating protocol. First, try to break the spasm with a firm, sustained jaw thrust and give 100% oxygen with a tight mask seal. That often works.
And if it doesn't?
If that fails, you can try an oral or nasal airway. You must quickly deepen the anesthetic. But in severe cases, if the oxygen saturation is plummeting, you have to give a paralyzing dose of succinylcholine to forcibly relax those laryngeal muscles.
And once the spasm finally breaks, what's the next immediate risk you have to look out for?
Negative pressure, pulmonary edema, NPPE. This is the immediate, very dangerous downstream consequence of a severe laryngospasm. Right.
The pathophysiology is all about generating this massive, sustained negative pressure inside the chest. The patient is fighting to breathe against a closed glottis, creating a powerful vacuum.
And that suction pulls fluid into the lungs.
It literally sucks fluid from the pulmonary capillaries into the alveoli, leading to a very rapid, life-threatening pulmonary edema. On top of that, the sympathetic surge from fighting for air jacks up vascular resistance, which puts a huge strain on the left ventricle, driving even more fluid into the lungs.
That makes perfect sense. A purely mechanical stress causing a massive fluid shift.
Exactly. Management is then about oxygenation, often with PEEP and supportive care.
Okay, let's move to aspiration and gastric contents, probably the most famous complication of induction. What are the major risks here, and how strict are those MPO protocols?
The #1 risk factor is, and always will be, a full stomach. This just highlights why those MPO protocols are so critical. And they're very specific. 6 hours for solids, 4 for milk, 2 for clear fluids.
And what about other risk factors? Beyond fasting, any condition that reduces consciousness. So CNS problems, high intracranial pressure, intoxication, all of that dramatically increases the risk because the body's protective reflexes, the gag and laryngeal reflexes, are blunted.
If aspiration does happen, what's the sequence of events that leads to respiratory collapse?
It's devastating. When that acidic stomach content hits the lungs, it causes an immediate chemical pneumonitis, a severe non-infectious inflammation. The respiratory failure that follows is driven by a couple of things. Mainly, the alveolar capillary membrane gets destroyed, leading to a massive intrapulmonary shunt. Blood is flowing through the lungs but not picking up any oxygen. You also get widespread collapse of lung tissue, or atelectasis, which makes the hypoxemia even worse.
So prevention has to be absolutely rigorous, especially in high-risk patients.
Absolutely. It all revolves around strict fasting checks, and in high-risk cases, trauma, gut obstruction, certain neonatal conditions using a rapid sequence induction or RSI, sometimes even putting down a nasogastric tube to empty the stomach right before you start.
Let's cover our last big airway issue. Bronchospasm. How is this physiologically different from laryngospasm?
That's a crucial differential diagnosis, and examiners love asking it. Laryngospasm is obstruction at the vocal cords, the glottis. Bronchospasm is happening lower down. It's smooth muscle constriction in the smaller airways, the bronchi and bronchiole, so the resistance is inside the lungs.
And what are the main things that can trigger that intraoperatively?
The causes are a critical list to run through. Inadequate depth of anesthesia is a big one. The patient is reacting to the tube. Mechanical issues like a kinked tube or secretions, surgical manipulation of the trachea, or, and this is important, an allergic reaction.
To what?
To things like neuromuscular blockers, antibiotics, even latex. You have to rule out a simple mechanical block first.
And how does the ventilator tell you this is happening?
You'll see it immediately on your ventilator readings. A big jump in airway resistance leading to really high peak airway pressures. Clinically, you might hear widespread wheezing if you listen to the chest.
On the management.
It has to be fast. First, treat the cause. Check the tube. Deepen the anesthetic. Volatile agents are great bronchodilators. Then, pharmacologically, the mainstay is inhaled beta-2 agonists, like albuterol, through the circuit. In tough cases, you might use nebulized epinephrine, all while you're watching for hypoxia and rising CO2. So, moving past those immediate sort of anatomical problems of the upper airway, let's shift to the mechanisms that mess with gas exchange deeper in the lungs. This takes us from just managing airflow to managing blood gases.
Okay, let's start with hypoxemia. What are the key physiological reasons for low oxygen in the blood during GA?
There are 5 primary mechanisms, and you really have to know these. The 3 most important clinically are right-to-left shunt, which is venous blood bypassing ventilated alveoli, VQ mismatch, where ventilation and perfusion are out of sync, and impaired diffusion, which is less common.
And the other 2?
The other 2 are simply alveolar hypoventilation, not moving enough air, and giving a low concentration of inspired oxygen, a low FiO2. Shunt is the really tricky one because just turning up the oxygen doesn't fix it.
And what about hypercapnia, or retaining too much CO2? What drives that?
Hypercapnia is almost always from alveolar hypoventilation. This can be absolute, from opioids suppressing the drive to breathe, or relative, where CO2 production just overwhelms the body's ability to clear it.
And intraoperatively?
Intraoperatively, you're looking at things like the patient being too light and fighting the ventilator, equipment problems like a bad CO2 absorber, or critically, a massive increase in CO2 production. And the classic example of that is, of course, malignant hyperthermia.
The physiological effects of high CO2 are often on exams. We know it causes acidosis, but what does it do to the cardiovascular system?
That's crucial to recognize. The acidosis is a powerful signal, but the key clinical sign is direct sympathetic stimulation. This shows up as tachycardia and hypertension. So before you treat unexpected high blood pressure, you must always check the end tidal, CO2.
So management is really a troubleshooting exercise. If you see an acute drop in oxygen or a spike in CO2, what's the immediate sequence?
You rule out the fatal causes first. If oxygen drops, step 1 is turn the FiO2 to 1.0, full oxygen. Next, immediately check the tube position. An accidental endobronchial intubation is a key reason for a sudden deterioration. Once you've confirmed the tube is in the right place and the FiO2 is maxed out, then you start optimizing your ventilation settings.
Okay, now let's talk about atelectasis. It sounds simple, a collapsed bit of lung, but it's a huge driver of post-op problems.
It's pretty much unavoidable under general anesthesia, especially in the dependent parts of the lung. Atelectasis is caused by this perfect storm of factors. The patient is lying flat, pain stops them from taking deep breaths, the anesthetic agents themselves affect lung mechanics, and they can't clear secretions. All this collapse increases that right-to-left shunt-driving hypoxemia that can last for days.
You mentioned a really interesting concept called the high FiO2 trap, or absorption atelectasis. Why would giving more oxygen make lung collapse worse?
It's a fantastic physiological point. Normally, the air in our alveoli is mostly nitrogen, and nitrogen is critical because it's not really absorbed into the blood. It acts like a pneumatic splint, just holding the alveoli open.
Okay.
When we wash all that nitrogen out with high concentrations of oxygen, we remove that splint. The oxygen gets rapidly absorbed, and without the nitrogen scaffolding, the alveoli just collapse.
So the treatment for hypoxemia can actually contribute to the cause.
Yeah.
How do we prevent that?
Prevention and management involve using PEEP, positive and expiratory pressure, to mechanically keep the airways open, and performing recruitment maneuvers sustained high pressures to pop open the collapsed bits. But a word of warning, recruitment maneuvers can actually make hypoxemia worse for a moment, so you have to be careful.
And finally, in this section, barotrauma, physical injury from the ventilator.
Right. Barotrauma is when air leaks out of damaged alveoli into the surrounding spaces. It's a serious and common complication of mechanical ventilation, especially with really high pressures. It can show up as anything from subcutaneous emphysema to the most dangerous form, a pneumothorax.
And the ultimate crisis here is a tension pneumothorax. What defines that, and how is it managed in the OR?
A tension pneumothorax is a true medical emergency. Air gets into the pleural space but can't get out. It builds up pressure, collapses the lung, and shoves the heart and the other lung over,
Leading to circulatory collapse.
rapidly. Immediate management is a needle thoracostomy, a big needle in the chest to let that pressure out, followed immediately by a proper chest tube. And critically, you have to avoid aggressive hyperventilation after you diagnose it, because that can just make the air leak worse.
We're going to transition now to the cardiovascular system. This is where I think drug pharmacology and physiology really intersect. That balance between oxygen supply and demand is just critical for every organ.
Absolutely. This is often the most pharmacologically complex part of an anesthetic. You're constantly walking this tightrope between keeping the patient deep enough for surgery and maintaining their blood pressure.
So let's start with intraoperative hypotension. What are the three big mechanisms driving low blood pressure under GA?
We usually think about it in three buckets: hypovolemia, vasodilation, and pump failure. Hypovolemia is often from blood loss, and you always have to be worried about concealed lost blood that you can't see.
Right.
The second and most common cause is loss of sympathetic tone from the anesthetic drugs themselves. And the third is just plain pump failure, a drop in cardiac output.
Why is sustained low blood pressure so dangerous, and what's the actual threshold for organ injury?
It's all about end organ ischemia. The best data we have shows that the cumulative time a patient spends with a mean arterial pressure, or MAP, below 65 to 70, that time is strongly linked to higher rates of kidney injury, heart attack, stroke, and death.
So if we see the MAP drop below 65, what's the immediate management sequence?
Well, the initial step, assuming it's from anesthetic-induced vasodilation, is to give a peripheral vasopressor, like phenylephrine. That rapidly restores the pressure. This goes hand in hand with giving fluids.
But what about patients with a weak heart?
That's the key caveat. In patients with compromised cardiac function, just looking at the MAT isn't enough. You often need more invasive monitoring, like a transesophageal echo or a CVP line, to really guide your therapy so you don't fluid overload a failing heart.
Okay, now the opposite problem, hypertension. What causes those pressure spikes in the OR, and how does that change when the patient gets to the recovery unit?
Intraoperatively, it's often a reaction to something. The anesthetic is too light, there's a big surgical stimulus, or it could be physiological, high CO2, low oxygen. You also have to rule out rare things like pheochromocytoma or malignant hyperthermia.
And in the PCU?
Postoperatively, hypertension is very common, and it's usually driven by a huge sympathoadrenal surge. Most commonly, it's just uncontrolled pain. But before you reach for a drug, you have to rule out those correctable causes first, especially hypoxia and hypercarbia.
Once you've ruled those out, what drugs do you favor, especially in a high-risk cardiac patient?
Beta blockers like labetalol or esmolol are really the most rational first choice, especially if the high blood pressure comes with a high heart rate. They directly counter that sympathetic surge and are cardioprotective. The goal is to get the systolic blood pressure down below 160 pretty quickly.
And finally, myocardial ischemia. The underlying problem is always that mismatch between supply and demand.
Precisely. Ischemia happens when the heart's oxygen supply, which is determined by coronary blood flow, doesn't match the demand, which is driven by heart rate, contractility, and wall tension. And tachycardia is a huge threat.
Why is that?
Because it's a double whammy. It increases demand by making the heart work harder, and at the same time, it cuts supply by shortening diastole, which is when the coronary arteries actually fill.
So where in the whole surgical journey is the patient most vulnerable to this?
This is a really key insight from the data. The ischemia often doesn't happen in the middle of the case. It happens right at the end of anesthesia or immediately after surgery, up to 2/3 of cases.
Why then?
Because that's when you have the maximum sympathetic output, hypertension, and tachycardia, all maximizing the heart's workload just as the patient is recovering from the stress of surgery.
So what are the specific hemodynamic goals we're aiming for to keep that balance?
The goals are pretty rigid, especially for patients with heart disease. We want to keep the heart rate between 55 and 100.
Yeah.
A heart rate consistently over 100 is bad, under 55 is protective. And as we said, keeping that MAP above 65 to 70 is critical. Anesthesia is defined as a reversible, drug-induced state of unconsciousness. So the complications in this system, the CNS, happen when that state isn't perfectly maintained, or when reversal is delayed, or when the drugs have lasting cognitive effects.
Let's start with awareness under anesthesia. This is, it's a technical failure, but also a huge psychological and medical legal issue. What's the precise definition?
We define it as connected consciousness. It's the experience of the environment or your own body, the ability to form memories when you're supposed to be unconscious. And critically, it often happens when the patient is paralyzed, which is just terrifying.
What are the main risk factors for that happening?
It centers on two things: not enough anesthetic and masking the signs. Sometimes the anesthetic is kept intentionally light to keep blood pressure up in a very sick patient, or it's unintentional, maybe equipment failure. But the key masking factor is using neuromuscular blockers, because that takes away the patient's ability to move, which is the most obvious sign of being too light.
So if you can't rely on movement, how do you objectively monitor the depth of anesthesia?
The standard of care now involves using EEG-based monitors like the bispectral index, or BIS. It gives you a real-time number for anesthetic depth, so you can titrate the drugs much more accurately. You're aiming for a score between 40 and 60.
Okay, moving to the recovery phase. What about delayed emergence, when a patient just doesn't wake up on time?
Delayed emergence requires a really quick systematic differential diagnosis. It could be prolonged throat effects, especially in obese patients. It could be metabolic low blood sugar or severe hypothermia, or it could be something much worse, like an undiagnosed stroke that happened during the surgery.
And where do seizures fit into this picture?
Seizures are a sign of severe neurotoxicity or a profound metabolic problem. They can be a feature of very high body temperatures, say 40 to 42 degrees Celsius. But more immediately for us, they are the key neurological sign of local anesthetic systemic toxicity, or LAST-FLAU.
Let's focus on the geriatric population and those two big cognitive complications, POCD and postoperative delirium, or POD. What's the difference between them?
Postoperative delirium, POD, is an acute confusional state. It fluctuates over hours to days, and it happens right after surgery up to about a week. POCD, postoperative cognitive dysfunction, is more of a long-term decline that can last for months or even years.
The rate of POD in the elderly is shockingly high. I imagine an MD examiner would want us to know the risk factors inside and out.
Absolutely. POD is the most common surgical complication in older adults, with rates from 5% all the way up to 50% in things like hip fracture surgery. We break the risk factors down into two types.
Okay.
First are the predisposing factors, the things inherent to the patient, age over 65, and pre-existing cognitive impairment or dementia. That is the single biggest risk factor. Severe illness, poor vision or hearing, and substance abuse are also on the list.
So we should be screening for this beforehand.
It's now a mandatory part of geriatric assessment, using tools like the MiniCog.
And what are the precipitating factors? The triggers from the hospital environment itself?
These are the acute insults. The size and length of the surgery is a big physiologic stressor. Certain medications, opioids, benzos, and especially anticholinergics, are known to cause delirium. Sleep deprivation is huge. And there's growing evidence that very deep anesthesia, what we call burst suppression on the EEG, might increase the risk.
How do we objectively assess for it post-op?
The gold standard tool is the Confusion Assessment Method, or CAM test. It's a quick 4-point check for changes in mental status, inattention, and disorganized thinking.
Given how common and devastating this is, what are the key prevention strategies?
Prevention is overwhelmingly non-pharmacologic first. It's a bundle of things. Cognitive stimulation, getting the patient moving early, reorienting them, making sure they have their glasses and hearing aids.
And pharmacologically?
Strict pain control, preferably using non-opioid techniques. We avoid those delirium-inducing drugs as much as possible. If a patient gets severely agitated, a small, titrated dose of haloperidol can be used to manage the symptoms.
All right, let's move to complications driven by cellular chaos. This brings us to that classic, terrifying crisis, malignant hyperthermia.
MH is the absolute litmus test for crisis management in our field. It's a rare but rapidly fatal genetic disease that demands a perfect algorithmic response.
Let's start with the basic cause and triggers.
So MH is an autosomal dominant condition. It's a genetic susceptibility. It's triggered by two classes of drugs. All the volatile halogenated anesthetics like sevoflurane and desflurane, and the depolarizing muscle relaxant succinylcholine.
And what's safe to use?
Nitrous oxide and xenon are considered non-triggering and are safe in susceptible patients.
Can you describe the detailed pathophysiology? What's the defect that causes the cellular chaos?
The core defect is uncontrolled skeletal muscle metabolism. It's usually from a mutation in the ryanodine receptor, or RR1, on the sarcoplasmic reticulum in the muscle cell.
Okay.
Normally, calcium release is tightly controlled. In MH, the trigger drugs cause a massive, sustained, uncontrolled flood of calcium into the muscle cell. This huge calcium surge causes sustained muscle contraction, or rigidity, and it uncouples oxidative phosphorylation in the mitochondria.
Which means?
It means energy production becomes incredibly inefficient. It starts generating massive, uncontrolled heat and burns through oxygen at a furious rate.
So what's the sequence of clinical signs? What's the single most important early warning?
The diagnostic cascade is key. The most consistent and earliest sign, often before the fever, is a sudden, unexplained, and sustained rise in the end-tidal CO2. It's a direct measurement of that massive increase in metabolic rate.
And what follows that?
That's usually followed very quickly by unexplained tachycardia, often over 140 beats per minute, and arrhythmias.
And the muscle and temperature signs.
You'll see generalized rigidity or masseter spasm if succinylcholine was used. Then you get a severe mixed metabolic and respiratory acidosis, profound hyperkalemia, and a rapid rise in CK levels. The rapid rise in core body temperature, more than 2 degrees Celsius an hour, is often a later sign, but it can get up over 42 degrees, which is just catastrophic.
This is a classic Viva question. What's the differential diagnosis for MH? How do you distinguish it from other hyperthermic states?
You have to instantly differentiate it from neuroleptic malignant syndrome, thyroid storm, pheochromocytoma, and sepsis. The things unique to MH are that speed of onset, the profound rigidity, and that severe unexplained spike in the ATCO2.
Let's run through the crisis management protocol, the gold standard response.
Okay, it's immediate simultaneous actions. 1, discontinue triggers, stop all volatile agents and succinylcholine. 2, hyperventilate. Flood the circuit with 100% oxygen at high flows. 3, administer dantrolene.
The specific reversal agent.
The specific reversal agent. It works by inhibiting further calcium release. You give 1 to 2 milligrams per kilogram as a rapid IV bolus and repeat it until the symptoms resolve. 4, aggressive cooling. Ice packs, cold IV fluids, everything. And 5, treat complications. Manage the hyperkalemia and acidosis to stabilize the heart.
You mentioned neuroleptic malignant syndrome as a key differential. How is that different?
NMS is caused by central dopamine receptor blockade from things like antipsychotics. It shares hyperthermia and rigidity, but the mechanism is central, not peripheral muscle calcium release. Management is stopping the drug, cooling, and sometimes using dopamine agonists. Dantrolene is supportive, not specific.
And what about simple heat stroke?
Heat stroke is just an uncontrolled rise in body temp without a change in the hypothalamic set point. The key thing here is that dantrolene is completely ineffective because there's no underlying muscle receptor problem. Management is purely supportive and aggressive cooling.
Let's quickly touch on the opposite, hypothermia. Why is keeping the patient warm so fundamental in GA?
Hypothermia, a core temp below 36 Celsius, is insidious but pretty easy to prevent. Its complications are systemic and serious. It causes peripheral vasoconstriction, which is bad for grafts. It increases the risk of residual paralysis by slowing drug metabolism, and it's strongly linked to adverse cardiac outcomes. Right, so the very drugs we rely on to create unconsciousness, analgesia, and immobility are themselves potent and can cause severe reactions.
Anaphylaxis under GA seems particularly dangerous because the patient can't tell you what's wrong. So how do we recognize it?
You have to rely entirely on the nonverbal signs. You have to think anaphylaxis if you see acute, severe, unexplained bronchospasm, or most commonly profound hypotension, that just isn't responding to fluids and vasopressors.
And the most common culprits.
The neuromuscular blocking drugs and antibiotics are the most common implicated agents.
And management.
It follows standard advanced life support guidelines. You stop the suspected drug immediately, give aggressive fluid resuscitation for the vasodilation, and then titrated doses of epinephrine to restore vascular tone and treat the bronchospasm.
Okay, what about local anesthetic systemic toxicity, or AST? It's usually associated with regional blocks, but it's relevant in GA too.
Very relevant. AST happens from an accidental IV injection or just an excessive dose. The toxic mechanism is the non-selective blockade of sodium and potassium channels in excitable tissues, like the brain and the heart.
What are the distinct neurological and cardiac signs?
The neurological signs, tinnitus, a metallic taste, agitation, are classic, but they're often masked by the general anesthetic. The cardiac features are what we really fear: conduction problems, a wide QRS complex, profound bradycardia, and then intractable VFib or asystole. And agents like bupivacaine are much more cardiotoxic than ropivacaine.
How do you manage that crisis?
The protocol is unique and absolutely essential. Besides supportive care, the key is the immediate administration of lipid emulsion therapy. The lipid emulsion acts like a lipid sink, grabbing the lipophilic local anesthetic molecules and sequestering them away from the heart.
Let's revisit residual neuromuscular blockade. Why do the effects of muscle relaxants sometimes linger into the post-op period, and what's the impact?
RNMB is a big problem. It's strongly associated with an increased risk of aspiration, airway obstruction, and general post-operative respiratory complications. The key risk factors are hypothermia, which slows drug metabolism, and respiratory acidosis.
And how do we objectively check for it in the recovery unit?
Intraoperatively, we use train of 4 monitoring. In the PCU, the Brimage scale is often used to assess motoblock. A scale of 0 means free movement. A scale of 3, where the patient can't move their leg at all, represents a profound residual block that needs immediate pharmacological reversal.
This whole next section deals with injuries that happen because GA basically switches off our protective reflexes. What's the core principle of preventing them?
The core principle is recognizing that because the patient can't move or complain of pain, the anesthetic team has to be the sole defender of their musculoskeletal and vascular integrity. So it's all about meticulous planning, secure positioning, and a lot of padding.
What are some specific examples of severe nerve and pressure injuries?
We see peripheral nerve injuries, which are often exacerbated by positioning stretch, hypotension, and patient comorbidities like diabetes. We also see pressure sores, compartment syndrome, and tragically, visual loss ischemic optic neuropathy, especially in long-prone spine surgeries due to pressure on the eye.
Let's talk about a unique mechanical hazard, venous air embolism.
VAE is a major risk anytime the operative site is more than 5 centimeters above the right atrium. This creates a negative pressure gradient that can suck air into open veins. The classic example is sitting neurosurgery. The air can airlock the heart, leading to sudden circulatory collapse.
Okay, let's turn to our special population, starting with the elderly. We talked about cognition, but their vulnerability is really system-wide.
Absolutely. The geriatric patient has profoundly impaired homeostasis and reduced physiological reserve. This is a critical area for examiners. They have reduced cerebral blood flow regulation, impaired baroreflexes, and reduced kidney and liver function. Drug half-lives are prolonged. You have to use lower doses and titrate very, very cautiously.
And what are the key concerns unique to pediatrics?
Pediatrics is all about unique physiology and anatomy. Their airways are different, bigger tongues, smaller larynx. Laryngospasm is much more common. They also have a higher incidence of emergence delirium. And you have to be ready for special airway pathologies like extrinsic compression from a cystic hygroma.
We should also touch on the obese patient.
The morbidly obese patient presents challenges with respiratory mechanics and drug dosing. They have a severely reduced functional residual capacity, which means they desaturate very quickly on induction. They are high risk for a difficult airway and aspiration. And drug dosing is incredibly complex. You have to use different weight calculations for different drugs. At the end of the day, modern high-quality practice isn't just about managing crises. It's defined by prevention, systems-based safety, and continuous quality improvement.
So let's focus on prevention. How does the ASA physical status classification help us with risk stratification at the very beginning?
The ASA-PS classification is fundamental. It quantifies the patient's physiological reserve and overall mortality risk. A higher ASA class, like a 3 or a 4, tells the whole team that this case needs meticulous planning, more monitoring, and maximum optimization beforehand.
And what does that proactive optimization look like for chronic conditions?
It means getting clinical control before the stress of surgery. So stringent control of severe hypertension, aggressive glucose management in diabetics, optimizing heart failure. These steps reduce the baseline risk of a major adverse event.
What's the minimum standard for intraoperative monitoring to make sure we catch these things early?
Standard monitoring is continuous ECG, pulse oximetry, capnography, and temperature. For high-risk cases or those needing paralysis, we add neuromuscular monitoring. And for cases with a high risk of awareness, we mandate depth of anesthesia monitoring like BIS. These aren't just checks, they're our primary defense.
And finally, the systematic approach of checklists and protocols.
The implementation of standardized algorithms for difficult airways, for MH, for trauma is absolutely essential. They standardize the response and eliminate cognitive chaos during a crisis. Fundamentally, you have to address all the modifiable risks, avoiding hypoxia, hypercarbia, hypothermia, and severe hypotension.
Okay, turning to the medical legal aspects, you mentioned awareness and nerve injury. What's our duty regarding informed consent?
Informed consent has to be comprehensive. It must explicitly include discussion of specific, serious, though rare, risks. This includes the possibility of peripheral nerve injury, which is often not preventable but has to be discussed, and the rare but devastating risk of awareness.
And the final cornerstone, documentation and critical incident reporting.
Detailed, contemporaneous documentation is paramount. It provides a factual record of your decisions and the patient's response. And engaging with systems like the National Audit Projects or internal hospital reporting is vital. It's how the specialty learns from failures and improves safety for everyone.
This has been an incredibly rigorous breakdown, moving way beyond a simple list to a deep, mechanistic understanding of risk and rescue. The systematic approach caused to pathophysiology to management is clearly the key takeaway.
To really solidify this knowledge, especially for someone focused on exams and clinical application, let's distill 3 final concrete exam-focused tools. First, a rapid revision summary. The distinction between temperature syndromes, remember this. Delirium and seizures are typically associated with core temps between 40 and 42 degrees Celsius. Contrast that with malignant hyperthermia, where the first and most diagnostic sign, that unexplained rise in end-tidal CO2, precedes the fever. The fever is a result of the hypermetabolism, not the cause.
That's a great distinction.
Second, a management flowchart for unexplained acute hypotension. If you face this, think algorithmically. Rule out hemorrhage, rule out mechanical ventilation effects, rule out aspiration. If those are ruled out, you're dealing with sympathetic loss from your anesthetic drugs. Treat that immediately with vasopressors to get and keep the MAP above 65 to 70.
Simple and effective.
And finally, a last-day Viva safety checklist, the crisp one-liners examiners expect.
The risk of complications can potentially be higher during extubation than during intubation.
Intraoperative MAP must be maintained greater than 65 to 70 mmHg to prevent end-organ ischemia, kidney injury, stroke, MI. And number 3, the most powerful single predisposing factor for postoperative delirium is pre-existing chronic cognitive impairment.
That mechanistic algorithmic approach is exactly what you need to transform static information into flexible, applied knowledge in a crisis. The journey through the sources ends here, but your preparation doesn't. Keep reflecting on those critical physiological windows and the systems-based approach to patient safety, and we'll see you for the next deep dive.